Assalamu alaikum wa rahmatullah. Today we are going to discuss a very important and a very common topic for all general practitioner, because whatever your specialty, you might have a case of abdominal pain, and one of the items you have to exclude in each case is appendicitis. So it's very common. If you are an obstetrician, a pediatrician, internal med, and sure surgeons, all of you might have a case of abdominal pain and appendicitis. Either you include or exclude from the differential diagnosis. As we use, this is the items we are going to discuss in this lecture: the anatomy, the incidence, the presentation, the differential diagnosis, which is very important, how to investigate and treat a case of that, and a brief idea how to do appendectomy, what are the methods to do appendectomy. But as I used to discuss any topic with you, I have to start with the surgical anatomy, some anatomical notes that might help me in understanding appendicitis. The first one, if you see here, the appendix has narrow lumen. It's a blind tube, blind here, and it has opening here with the cecum. This lumen is very narrow. What's the value of that? It can be easily obstructed, even with fruit seed. It can be easily obstructed with fruit seed. And you will understand this is the first step of acute appendicitis: obstruction of this narrow lumen with fruit seed. This is length. Also, this issue is very important. This, what we call the base of the appendix, this is the only fixed part. What is the value of this knowledge? The value is that when you are going to search for the appendix in appendectomy, you search for the base, you search for the fixed part. And we have a very clear surgical landmark. In the colon here, we have what we call the three tinea coli. The three tinea coli meet each other at this base of the appendix to form a complete muscle coat. So if you do not find the appendix, when you see the cecum, follow the tinea coli, you will reach the base, which is, as I told you, fixed point. Again, when you are going to do open appendectomy, you have to make incision pass through this point, which we will know later with the McBurney's point in the next slide. So this is the value of knowing that the only fixed point of the appendix is its base. But as you see in the diagram, you will find the apex has many sites like that. It might be retrocecal, it might be pelvic, paracecal, subcecal, pre and post ilial. Again, what is the surgical significance of that? This will affect the clinical picture. For example, here, if the appendix is behind the ileum like that, there might be irritation of the ileum. The patient might complain of diarrhea. Also, if the tip of the appendix here in the pelvis, it might irritate the rectum, it might irritate the bladder, and might be urinary symptom, something like that. It's not only that, if complicated by mass or abscess, the site of the mass or the site of the abscess depends on the site of the tip. So we know two very simple information: the base is fixed, we know it's significant, and the tip is variable, and also we know it's significant. I told you, if the base is fixed, we have to know where is it on the body of the patient. It will be marked here with some doctor describe it. His name is McBurney's, and it is called McBurney's point. As you see, it is in the junction between line joining the umbilicus to the anterior sphenic spine, junction between the lateral third and the medial 2/3 of a line passing from the umbilicus to the anterior sphenic spine. It is the site of the base of the appendix, which is the only fixed part, as we discussed. If you are going to do gridiron incision, you have to pass through this point. It's also the area of maximum tenderness of the appendix. To complete the anatomy, if you see the appendix here, this is the cecum, this is the appendix, this is the base of the appendix at the tip. You can see what we call the mesoappendix. The mesoappendix is a fold of peritoneum containing the appendicular artery and the appendicular vein. You see this appendicular artery moving like that, and giving branches vertical to supply the appendix. This appendicular artery is endoartery. What's meant by endoartery? Yeah, it has no collateral. So if it is thrombosed, it will lead to gangrene of the appendix, immediately gangrene of the appendix. If you notice, the artery starts away from the appendix, and when we go laterally, it becomes even adherent to the wall of the appendix near the tip. Again, if there is obstruction here during appendicitis, there will be edema of the tip. It will compress the artery here, leading to thrombosis. Thrombosis of end artery will lead to gangrene and perforation. And that's why perforation of the appendix is common complication. and also it occurs mainly on the tip. It might occur at the base here, but by far it's more common on the tip. This is the blood supply, and this is the surgical significance. There is some congenital anomalies that might affect the site of appendix. One of them is somewhat we can see subhepatic. Subhepatic, when the cecum is high up in the abdomen like that, you will find the appendix behind the liver. The only significance of this issue is if this patient having appendicitis, it might mimic the clinical picture of cholecystitis, and you have to differentiate between them. This is the subhepatic appendix. In very, very rare situation, you might find appendix on the left side like that in patient with situs inversus totalis. I have seen I don't remember 2 cases or 3 cases maximum in my life, and thanks God the 3 know before the surgery they have situs inversus totalis. They told me I have the apex of the heart on the right side, not on the left side, something like that. They know by one way of another. Agenesis or double, some rare situation. I'm not interested for undergraduate to know these, but these are the congenital anomalies: subhepatic and situs inversus totalis. The microanatomy, the last slide in the anatomy, is the histology. The microanatomy, if we have a cross section like here of the appendix, we'll find the mucosa. Sure, it's columnar, but during this mucosa we'll find cells called Kolchetsky cells. This Kolchetsky cells is a source of carcinoid tumor. Take care, the appendix is one of the commonest sites in the abdomen that might have carcinoid tumor. You will find a big mass of the appendix, and this mass might be carcinoid tumor. That's why you have to send each removed appendix to the pathology to exclude this. And this patient might have carcinoid syndrome, and if the situation like that, the surgery differ. If carcinoid tumor of the appendix, you have to do right hemicolectomy and not appendectomy only, something like that. You have to read about carcinoid tumor of the appendix, rare situation. In the submucosa here, there is extensive lymphoid aggregation, and that's why we know the term that the appendix is called the tonsil of the abdomen. Also, if you remember an old issue called staging laparotomy in lymphoma, if you study lymphoma, some before CT we do staging laparotomy. We do laparotomy incision and take multiple biopsies from the abdomen to stage the lymphoma. It's called the staging laparotomy. One of the structures removed was the appendix because of its high lymphoid aggregation. The muscular coat, we have only one significant here. You remember the outer longitudinal is complete. It's not like the colon having 3 tinea coli. The 3 tinea coli merge at the base of the appendix to form complete outer longitudinal muscle layer, and we can follow the tinea coli to reach exactly the base of the appendix. And finally, the visceral peritoneum, which is the peritoneal covering. This is also very important in the clinical picture. When the lumen of the appendix is obstructed, you will find the appendix is distended. It will lead to a stretch of this visceral peritoneum, leading to visceral abdominal pain, which starts around the umbilicus. This is the first pain experienced in appendicitis, and the pain will shift to the right iliac fossa as we are going to discuss. We finished now the anatomy. What are the diseases that might happen to the appendix? Sure. Our main topic here is acute appendicitis, but it might be recurrent acute attack, might be tumor, adenocarcinoma, but carcinoid tumor. You have to know some information about carcinoid tumor of the appendix. You are going to study this carcinoid tumor in the oncology module. Starting our main topic, which is acute appendicitis. First, sure, it will be exactly the instance. You have to know it is the most common cause of acute abdomen, and that's why any general practitioner must know how to diagnose appendicitis. The peak instance is between 15 and 35 of age. This is the peak instance. It doesn't mean it is rare in children. It's not rare, it's common in children, but rare in infant. Rare in infant below 2 years because the lumen is still wide and it's difficult to be obstructed, but common in children, as I told you. The sex, somewhat, the male is slightly more than female. There is common in highly civilized countries, but I want to tell you something. There is a dramatic decrease in the incidence in Europe and America. I don't know, might be after some years you come and tell me, take care doctor, It's no longer the most common cause of acute abdomen nowadays because of this dramatic decrease in its instance in Europe and America in the past 30 years. I'm not sure this dramatic decrease in instance will continue or not. This is the instance, whatever what I'm interested. It's common situation, most common cause of acute abdomen till now, the peak instance between 15 and 33, rare in infants. What happened? What happened for the appendix to be inflamed? Starting like that, as I told you, start with, in most of the cases, about 2/3 of the cases, start with obstruction of the lumen. What might obstruct the base of the appendix? Might be very small thing like small piece, might be hard feculus, come and impact here at the base of the appendix, leading to obstruction. When obstruction occur, stagnation, which transform the non-pathogenic organism into pathogenic one, leading to inflammation of the appendix. As I told you, what might obstruct the lumen? It might be feculus, it might be fruit seed, it might be lymphoid hyperplasia, stricture, but take care. This is the common feculus and fruit seed, but this is the most dangerous. It might be obstructed by cancer cecum, might obstruct, and the patient presented with appendicitis. What's the value of this knowledge? Take care. If you diagnose appendicitis in old age, you have to examine the cecum, because even if the appendix is inflamed, might be the cause cancer cecum that obstruct the base of the appendix like that. It might be a round wart. Another situation which is less common, less than 1/3 of the cases, might be without obstruction like that, but if you understand the pathology well, you will find there is a stagnation also. This occurs in patient with constipation, with high intracolonic pressure. If the pressure here is high, so the evacuation of the appendix is somewhat disturbed. Stagnation also occurs, non-pathogenic organisms turn to pathogenic, and inflammation start. When infection occurs, usually it is a mixed of organisms, but the most common sure is the E. coli. But usually inflammation of the appendix is caused by a group of bacteria. After the instance and etiology, we'll discuss the pathology. Whatever the mechanism, obstructive or non-obstructive, stagnation occurs, the bacteria becomes pathogenic, so infection starts at the mucosa, which is called catarrhal appendicitis. Catarrhal appendicitis, the inflammation is limited to the mucosa, might extend to submucosa. It leads to swelling of the appendix. This swelling stretches the visceral peritoneum. This distension, this is called the visceral pain. We are going to discuss in more details in the clinical picture. This is acute catarrhal. Take care. In this stage, it is still reversible. You might use intravenous antibiotic and the inflammation is resolved. But if it progresses, this situation transforms from catarrhal one into separative one. In separative appendix, the appendix is full of pus. In this situation, the appendix is full of mucus only. But if the situation increases, the mucus turned into pus, and this appendix is full of pus, and in this situation surgery is mandatory. Again, if we wait more, as I told you, a swollen appendix compresses the artery, leading to thrombosis. Thrombosis leads to gangrene, so the appendix will be gangrenous like in this photo, and the gangrene might lead to perforation, and perforation leads to diffuse peritonitis. We know how the inflammation proceed. Start at the mucosa, then extend to submucosa. The whole appendix becomes full of pus, and finally it becomes gangrenous if I do not interfere, and the gangrene lead to perforation, as I told you. Okay, starting with the very important issue you have all know, which is the symptom. Sure, the main symptom is abdominal pain, and you have to analyze the pain very accurately. If you ask the patient, he will tell you the pain starts here around the umbilicus. It was not well localized. He will figure it with his hand all around the umbilicus like that. It is dull aching. I don't know its character exactly, but after that the pain is shifted to the right iliac fossa, and if it is well localized, the patient can point exactly to the site of pain, and the pain is stitching or stabbing. So abdominal pain is usually the first symptom. Starts around the umbilicus and then shift to the right iliac fossa, constant in nature with intermittent abdominal cramp. The typical scenario I discussed, the pain starts around the umbilicus, which is the visceral pain, and then shift to the right iliac fossa, which is the somatic pain. This is not well localized. This is well localized. This classic pain occurs in 50% only of the cases. Take care, sure, pain occur in 100% of the cases. Is there any other symptom? By the way, you have to compare between two types of pain, visceral pain and parietal pain. You have to know what is the cause of each. The cause of visceral pain is the stretch of the visceral peritoneum. The cause of somatic pain is irritation of the parietal peritoneum by the inflamed appendix. The visceral one is not well localized, is dull aching, but the other one is stitching or stabbing and well localized. The patient can point to the site of pain. Pain is the main symptom, 100% of cases. What are the other symptoms? One of them is anorexia. Also, anorexia occur in 100% of cases, particularly in children. If you ask the patient who want to eat, he will never eat anything during inflammation of the appendix. We have also nausea and vomiting. The nausea and vomiting caused mainly because pain leads to pylorospasm. This pylorospasm leads to nausea, which occur in 90% of cases, and vomiting in 79% of cases. But usually if the patient vomit once or twice, and he usually describe, I want to vomit, but I didn't vomit, or I just vomit the gastric juice because I don't want to eat. This is the scenario. Again, one of the very important point here, you have to know that vomiting always follow the onset of pain. If vomiting comes first and the patient experiences pain, this is in many situations against the diagnosis of appendicitis. Usually in appendicitis, pain comes first, then vomiting. That's why if the patient having multiple complaints, I have to arrange them chronologically, which comes first. So in our situation, pain first, then vomiting. Constipation. In most cases, there is constipation. It might be the cause, and the hard feculus go to obstruct the base of the appendix. In very, very rare situation like post-ileal appendicitis, there might be diarrhea. But if you know the incidence is less than 1%, it might be behind the ileum. These are the symptomatology. What about the general examination? The general examination, the patient looks ill. Ill-appearing, quiet child who is lying very still in bed with the legs flexed is much more a cause of concern. You must be more interested if the patient stay calm in bed. If the patient moves right and left screaming from pain, it is not appendicitis, because the pain of appendicitis increases with movement. Every time you move, the inflamed appendix will hit the parietal peritoneum, leading to severe pain. So the patient stay calm, very still in bed. Okay? What about the temperature? It's inflammation. But one of the character of the appendix, when it starts, usually it's low-grade fever, less than 38 degrees centigrade. Usually like that. If the condition started with high-grade fever, it might be something else rather than appendicitis. But if the appendix is complicated and the complication occurs at least 1 to 2 days after the onset of pain, you might experience high-grade fever, 39 or more, if complicated with peritonitis or appendicular abscess. But it occurs, as I told you, about 48 hours after the onset of symptoms. But with the onset, usually low-grade fever. I'm just not telling there is fever. I tell you what are the clues it help you to diagnose. Is it appendicitis or not? Sure, there is tachycardia. You know when the temperature increase 1 degree centigrade, the pulse increase 10 beats per minute. If you examine the patient abdominally, you will find many symptoms like that, but the most important, the one with big font like this. Localized tenderness. What I mean by localized tenderness, if you examine the abdomen, you ask the patient first, before you palpate, tell me which part you have pain in which part of your abdomen. He will point to the right iliac fossa. Okay, I'm going to start away from this. I start from the left iliac fossa. When you examine, you will find all the abdomen is free, but pain only in the right iliac fossa. It's called localized tenderness. And also localized rigidity at the McPhernis point. Rigidity, it's a reflex spasm of the overlying muscle over the inflamed appendix. It decreases the trauma to the appendix and trying to decrease the pain. So, very two important signs. Localized tenderness and localized rigidity. And you understand what's meant by localized. Localized means at the McPhernis point. The other one is rebound tenderness or Rosenberg sign. The rebound tenderness, you ask the patient to take a deep breath, you deeply palpate the right iliac fossa, and you suddenly release your hand. The patient experiences a severe pain, because when you release your hand, the inflamed appendix will hit the parietal peritoneum vigorously. Take care. I don't advise you to do this. You lose the trust of the patient. He might think that you deceive him because you suddenly remove and he experienced a severe pain. You might do the same by asking the patient just to cough. When you ask the patient to cough, he will control the severity of cough. When he cough, the intra-abdominal pressure increase and let the appendix, inflamed appendix, hit the parietal peritoneum, doing the same maneuver but with the patient control. These are the main three signs during palpation of the abdomen: localized tenderness, localized rigidity, and rebound tenderness. We have another signs. You might know. If you know the first three, you might proceed to the others. If you do not proceed. Please do not proceed. Rovsing sign, it's called crossed tenderness. What's meant crossed tenderness? When you palpate deeply on the left side, the patient experiences pain on the right side. That's why we call crossed tenderness. What's the explanation? When you compress on the left side, you make movement of the colon, movement of the gas of the colon that move the cecum, that move the appendix, leading to pain. Also, Rovsing sign, you have to know this term because it's somewhat difficult to describe all this. It's called Rovsing sign. Blomberg sign is crossed rebound tenderness. Pain increased with sudden release of pressure on the left iliac fossa, not on the right, and that's why again it's called crossed. Cooper sign on obese. In obese patient, you might not be able to feel the tenderness and rigidity unless you ask the patient to lie on his left side, so the abdomen or his belly will be away from the iliac fossa. You can palpate it easily. There is Sharon triangle of hyperesthesia. I will show you in the following slide. Finally, digital rectal examination is beneficial if you suspected pelvic appendicitis. History examination is sensitive like this. You can diagnose most of the cases by only history and examination. We still have many slides before to reach the investigation, by the way. But till now, we finished the main symptoms and the main sign. As I told you before, the tip of the appendix, the site of the tip of the appendix differ, and this might affect the clinical picture by one way or the another. The most common one is this is changes in the presentation according to the site of the tip of the appendix. If the appendix is retrocecal and the tip is over the psoas muscle near the ureter, so it will affect the clinical picture like that. Because it's near the ureter, it might be hematuria, because it irritates the psoas muscle. There is a psoas spasm, and you can see it. You will find the patient lying on the bed with doing flexion of the hip. Flexion of the hip. If you want to elicit and to be sure there is psoas sign, it's called Coop psoas sign due to psoas spasm. You have to do this. You have to do extension of the hip joint. How I'm going to do extension of the hip joint? Let the patient lie on his left side and trying to push his limb backward. You do extension. The patient experience pain. This is called Coop psoas sign and caused by spasm of the psoas muscle due to irritation of the psoas by the retrocecal appendix. This is first position. The second position is the pelvis. When the appendix is in the pelvis, it irritates the bladder leading to frequency, irritates the rectum leading to diarrhea, but also leads to spasm of obturator internus muscle. It's called Coop obturator or Coop sign. McFadden sign, you might experience it only in children because micturition leads to pain, because when the bladder moves hit the pelvic appendix, so the child usually postpone micturition. This postponing micturition because of pain in appendicitis is called the McFadden sign. Again, the clinical picture is big, but the classic one: localized tenderness, localized rigidity, and rebound tenderness. We can add also Rovsing. Remember, we finished the retrocecal appendix, and now we're discussing the pelvic appendix. The third position is post-ileal. In post-ileal appendix, somewhat deceiving. Why it's deceiving? Because it might irritate the terminal ileum leading to diarrhea. And you know, it's more common to have constipation with appendicitis. Second, the pain does not shift. What's meant by the pain does not shift? The visceral pain occur around the umbilicus because of the embryological development, but also the parietal pain when this appendix is inflamed. This tip hits the parietal peritoneum also around the umbilicus, so the visceral pain and somatic pain both are around the umbilicus, so the pain is no shift. These two items is somewhat deceiving, misleading, but thanks God the post-ileal appendix is very rare position, and not all of them becomes inflamed, so it's a rare situation. The last item, the subhepatic appendix. If you remember the slides of embryology, sometimes the cecum is high up in the abdomen and the appendix is behind the liver. You have to compare between it to differentiate it from cholecystitis. The age is younger in this patient. The pain starts around the umbilicus in case of appendicitis, and also the hyperesthesia here in the Sharon triangle. This is one of the items in the clinical picture. This triangle is between the umbilicus, symphysis pubis, and the anterior superior iliac spine. This triangle, the patient experiences hyperesthesia. In acute cholecystitis, the hyperesthesia over the lower part of the scapula. Special population in children, usually the peritonitis is much more manifest. Why is that? Because the omentum is short. Many factors, by the way. One of them, the patient is not cooperative. He cannot give you a detailed history. He will not allow you examine comfortably. But if it perforates, usually the omentum is short, cannot surround the appendix, leading to diffuse peritonitis. Also, in old age, the prognosis, if it occurs, the prognosis is bad. I want to remind you, appendicitis in old age might occur, but you have to exclude cancer cecum. You have to examine the cecum. In old age, also because of the decreased immunity and atherosclerosis of the vessels, perforation and peritonitis are more common. Also in pregnancy, in pregnant women, as you see, when the gravid uterus go up in the abdomen, it pushes the appendix like in this picture here. In 3 months, by the 8th month, you will find the appendix just below the liver when the pregnancy goes up. What's the problem? When it's like that, also the uterus push the omentum away. If it perforated, it will lead to diffuse peritonitis. Also, the diagnosis is somewhat difficult because the pain is high up like that and might mimic pyelonephritis rather than appendicitis because the appendix is high up in the 2nd and 3rd trimester. These again, how infant old age pregnancy affect the clinical picture. As you see, the clinical picture is so big, and that's why Alfredo gave a score to make it easy to diagnose. If you are confusing this is appendicitis or what, he collect the main symptoms like migratory pain, anorexia, nausea, and the main signs like tenderness, rebound tenderness, and the main investigation like elevated main investigation like leukocytosis and shift of pain, and give them, if it is present, I give them 1 mark or 2 mark accordingly. If they are not, I give them 0, and then I have the score of the patient. If the score is like that, I will discharge the patient. If the score between is like that, I will put him under conservation and repeat evaluation later on, few hours later. If the score between 7 and 10, I will do immediate surgery. From also this score, you will find that the tenderness, localized tenderness in light iliac fossa is very important, 2 marks. Also leukocytosis is very important, another 2 marks. This is again Alfredo score in another way. In some region, they have another score is called Ripassa score. This Ripassa score, it's more detailed score and put in situation the sex of the patient, the age, also symptoms, signs, and investigation. But it's more popular in South Asia, and they said it's more specific and more sensitive for appendicitis than Alfredo score. Not popular over the world, mainly in Malaysia and most of the countries in South Asia. This is a comparison between Alfredo, which is popular over the world, and Ripassa score. Now we finish the very big clinical picture, but take care. Some patient presented to you with complicated appendicitis, so the clinical picture again will be affected. What are these complications? These complications either appendicular mass, appendicular abscess, perforation, portal pyemia, or recurrent acute attack. I want to discuss the complication in the form of a story. The story is a battle between the appendix and the immune system. If the appendix succeed to win the battle and control the inflammation, so it will be localized and it will form a mass. If the immune system fail and the virulence of the organism succeed and the inflammatory process proceed, it will lead to perforation and peritonitis. If the battle is equivocal, so the immune system succeed to localize the infection, but later on the organism reactivated, it will lead to perforation of the appendix. Inside this mass, it leads to appendicular abscess. We will discuss portal pyemia later on. To study any complication of the appendix, you have to know how this complication occur, how to diagnose, and how to treat. You have to remember, you have to answer these 3 questions. Appendicular mass, it occurs at least after 2 days. No appendicular mass like that. Formed of what? It's formed from the inflamed appendix, surrounded by omentum, with adhesion between the terminal ileum and cecum. So adhesive band, omentum, appendix, ileum, and cecum, these are the components of a mass. That means the immune system succeed to localize the mass. What is the symptoms? Symptoms: pain in the abdomen, might be around the umbilicus shift, but at least 2 days ago. And now the pain is localized right iliac fossa. If you try to palpate, you might feel tender mass, but you have to know it's difficult to examine. Why it's difficult to examine? Excellent, because of the overlying rigidity and the tenderness. You cannot palpate it very well. To diagnose it, if you suspect it from the duration, you might ask for investigation. If you ask for ultrasound or CT of the abdomen, you will find a mass like that. Please, you have to take its dimension, because you are going to follow up, and you have to know this mass will grow or decrease in size. If the situation like that, you diagnose appendicular mass, what will be the treatment? The treatment is conservative treatment. This conservative protocol is described by 2 doctors. One of them is called Oshner and the other is called Sherin, and that's why we call it Oshner-Sherin regimen. It includes hospitalization, rest in bed, antibiotics, nothing per mouth, no enema, no analgesic, and the most important of all of these is observation at chart. I have to observe the pain increase or decrease, the temperature of the patient, leukocytosis, and with follow-up ultrasound, the mass in the right iliac fossa decrease or increase. Why I do that? Why I do not do appendectomy? Because I told you the immune system succeed to localize. Let him complete his job. This number 1. If you try to remove the appendix in this situation, you might injure the ileum or the cecum. What will be the fate after conservative? After conservative, 1 of 2. Either resolution, I discharge the patient. This occurs in 90% of cases. I discharge the patient and I do interval appendectomy later on. The other situation, during follow-up, you might find increased pain, hectic fever, increased tachycardia, increased size of the mass, leukocytosis. That means the appendix perforate within the mass. It means appendicular abscess. What will be the management here? The management will be drainage of pus and interval appendectomy after 6 months. Here, discharge and interval appendectomy after 3 months. If abscess occur, drain the pus and interval appendectomy after 6 months. The second complication, appendicular abscess. Mass is formed and perforation occur within it, so it takes longer time, 3 days or even more to occur. How to diagnose? Also pain, 3 days, shift, tenderness, mass. If you do CT or you do ultrasound, you will find fluid inside this mass, so you suspect. Also with the clinical picture, the hectic fever, the throbbing pain, the increasing size of the mass, the marked leukocytosis, all of these help to diagnose, plus CT and ultrasound finding. How to treat? I'm going to drain the pus. Again, I'm not going to remove the appendix. Just to drain the pus, and after 6 months, I'm going to do interval appendectomy. If complicated with pelvic abscess, how are you going to do? Please, I'm going to postpone it to the lecture of peritonitis, either localized or generalized. This is a type of localized peritonitis. The third complication is perforation. Okay, does perforation occur early or late? I told you, if there is a battle, if the organism succeeds the battle, so perforation occurs very early. So perforation occurs after 24 hours. occurs in which type of patient? These are the vulnerable patient, extreme of age, immunosuppression, diabetes mellitus, obstructed appendix with feculis, or pelvic appendix because of the deficient omentum. How you are going to diagnose? It will give the clinical picture of diffuse peritonitis. The clinical picture differ from appendicitis. The pain and the tenderness and the rigidity and the rebound tenderness becomes diffuse all over the abdomen, not only in the right iliac fossa. Also, the patient is severely toxic. If you do ultrasound, you will find the free fluid, you can aspirate pus. Also, this is the clinical picture of diffuse peritonitis, which we might study in more details in the lecture of diffuse peritonitis. In this patient, when the pus be present in the whole peritoneal cavity, the small intestine becomes paralyzed. It's called paralytic ileus. How to investigate a case of that? You ultrasound the free fluid, you aspirate pus. The treatment, these 4 items, you will discuss it in the lecture peritonitis in details. If you diagnose diffuse peritonitis, most probably due to perforated appendix, you have to do exactly midline incision, not grade iron incision. Midline incision, explore the abdomen, treat the cause, remove the pus, I mean toilet, and finally drain the pus. You have to put a drain. These are the 4 surgical steps during the treatment of diffuse peritonitis, whatever its etiology. Only treatment of the cause differ. In our situation, we just remove the appendix. After the complication, we will have portal pyemia, sorry. This is one of the rare complications nowadays when the organism or pus move from the appendix to the appendicular artery portal vein, leading to portal pyemia, pus in the portal circulation. It might lead to intrahepatic pyemic liver abscess. The treatment is intravenous antibiotic, and sure you have to remove the appendix. Another very important issue, and again it will be discussed in more details in another lecture, which is differential diagnosis of acute abdomen. It's better, for me, it's better to be discussed like that. This is written like that in Pili and Love textbook. If you suspect appendicitis, pain in the right iliac fossa, you have to think about the age of the patient. If you are dealing with a child, these are the differential diagnoses. You will think of gastroenteritis, mesenteric lymphadenitis, intussusception, Meckel's, and urinary tract infection. But he is adult, we are going to think of something else, like Crohn's disease, regional ileitis, ureteric stone, right side, perforated U, and pancreatitis. In adult female, we are going to add another differential diagnosis, like rupture, gravium follicle, pelvic inflammatory disease, pyelonephritis, ectopic pregnancy, torsion of the ovary. In elderly, we have to exclude cancer cecum, intestinal obstruction, diverticulitis. In each of these, you have to know what is the characteristic symptom, characteristic sign, and what's the investigation of choice to exclude or include. This will be discussed in more details in the seminar discussing diffuse peritonitis. So, 2 lecture or seminar linked to it. Peritonitis, diffuse and localized, differential diagnosis of acute abdomen. They cover these items in more details. This is a table differentiating between gastroenteritis and appendicitis. One of the main difference, vomiting before pain in gastroenteritis, pain before vomiting here in appendicitis. How I'm going to investigate? The investigation is like that. Laboratory, sure, you are going to ask for total leukocytic count. You will find leukocytosis. Sensitive but not specific. Urine analysis to exclude associated urinary tract infection. Pregnancy test, if positive, I have found ectopic pregnancy, one of the differential diagnosis. Imaging, sure, ultrasound and CT, both are important. Plain X-ray is less important in diagnosing appendicitis. Laparoscopy, especially in female and childbearing period, nowadays is so popular and it's used in diagnosis and treatment. What's the finding of ultrasound? Finding ultrasound, you are going to see this picture. You will find a blind tube with dilated caliber, more than 6 millimeter. If you try to compress it with the probe, it will be non-compressible. So more than 6 millimeter and non-compressible hypervascular. One of the other advantage of ultrasound, it can diagnose complication like mass or abscess or peritonitis. We know the finding in each. And in mass, we can follow up, is it increasing or decreasing. Also exclude other causes like gallbladder stones or ureteric stones. The limitation is retrocecal appendix. If this appendix is perforated, is no longer dilated, you might not see the appendix. You see pus in the peritoneal cavity, but you cannot see the appendix. CT scan also accurate in diagnosis, but we do not do it routinely. Wall thickness, wall enhancement, diameter more than 6 millimeter. You can see the feculus, appendicular feculus, and you can see the periappendicular inflammation. It's very sensitive, as I told you. X-ray finding, mostly it's normal. You might see focal ileus, something like sentinel loop, feculus mass. If it is perforated, the free air incidence is low. Why it is low? Because in most cases the appendix lumen is obstructed and no connection between the appendix and the cecum. Laparoscopy, I told you, especially in the female in childbearing period, because the wide range of differential diagnosis. Also, if it is negative appendix and I explore and remove the appendix, I might cause adhesions that might affect the future fertility. It's not only that diagnostic, it can also be therapeutic. I can remove the appendix, I can treat pelvic inflammatory disease, ovarian cyst, ectopic pregnancy. All of these differential can be treated by laparoscopy. Finally, I'm going to discuss the treatment. This is the summary of the treatment. That's what I want you to know. The treatment of acute non-complicated appendicitis is, immediate surgery, appendectomy. Either open or laparoscopic. Both are accepted. If there is appendicular mass, what we are going to do? Excellent, conservative. Which technique? Ochsner-Sherin. And I'm going to observe. If the patient improve, discharge, do interval appendectomy in 3 months. If not improve, change to abscess, drain the abscess. Appendicular abscess, exactly, drainage of the pus, then interval appendectomy after 6 months. Acute appendicitis complicated with diffuse peritonitis, the 4 steps. You remember the 4 steps? I'm going to remind you: exploratory incision midline, it's not gridiron. Second, treat the cause, remove the appendix. Third, remove the pus, it's called toilet. And the fourth is Bota-Dre. The last item, I'm going to give you a rapid idea how we are going to do appendectomy, and I will put a video on the model if you want to see how appendectomy is done, either open or laparoscopy. Here is the appendectomy. You give general anesthesia, you mark the patient like that, you do this gridiron incision crossing the McPerney's point, and it's called muscle splitting. What's muscle splitting incision? I split the muscle of the anterior abdominal wall in the direction of its fiber, not cut it. After I open all the layers and open the peritoneum, I'm searching for the cecum. When you find the cecum, deliver the cecum, follow the tinea coli. Now you can reach the base of the appendix. After you reach the base of the appendix, you ligate the mesoappendix and cut it. And after that, you ligate the base of the appendix, ligation here, crush here, and put your cochar here and cut here. Now the inflamed appendix is removed and we have only this stump remaining. This stump is either left like that, and it might cause post-operative or post-appendectomy adhesive intestinal obstruction, or some surgeon in open appendectomy try to bury it, doing bursa string suture and hide the base of the appendix like appear in this picture. What's the advantage of that? The advantage, there is no raw area here, so they claim it decreases the instance of post-operative adhesive intestinal obstruction. This step is optional. Many surgeons do not do this step. Again, in laparoscopic appendectomy, the technique differs. You use this stapler to stable the base of the appendix and to control the mesoappendix like that. It's very easy, but sure, it's somewhat much more expensive. This is the appendix after we remove it. This is the tip of the appendix, the base. This is the mesoappendix. Okay. Last item we are going to discuss is the post-appendectomy complication. There might be wound infection. This is the most common complication, especially when perforated and the field is contaminated. Might be ileus, DVT, adhesive. common cause of adhesive intestinal obstruction. To decrease its incidence, I bury the stump of the appendix, as I told you. Hernia, incisional hernia. Incisional hernia is supposed to be low because we do muscle splitting incision, but sometimes it occurs. But the main cause here is infection, wound infection, impaired healing, leading to weak scar, and that's the cause of incisional hernia. Another type of hernia might occur in case of appendicitis is inguinal hernia, direct inguinal hernia, because we might injure the ilioinguinal nerve during exposure of the appendix. This ilioinguinal supply the conjoint tendon becomes paralyzed, so the groin becomes weak and the direct hernia might occur. Fecal fistula, one of the dangerous complications, when the ligature of the base slipped, and the fecal content escape from the cecum through this stump. Finally, stump appendicitis. If you leave a long stump, might be inflamed, but again, it's a very rare situation.